Yes. Only Anusha is upstairs. She's in OPD. Arpita has gone to Poli. Sarthak is in. Yes. So CTP stalls and CDC guidelines, Center for Disease Control. Also, sir, some part I've taken from medicine as well. Yes. Good afternoon, everyone. The topic of my seminar today is physiology of sleep, and my moderator is Sanjeevani ma'am. So in this presentation, we'll be first of all going through what is sleep, then what are the various stages of sleep, effects of age on sleep, physiology of sleep, and finally the neurobiology of sleep. So what is sleep? Sleep is a behavioral state of psychomotor arrest with increased arousal threshold facilitated by sensory disconnection from the environment. So it is a reversible and a reoccurring event. So that is how we differentiate it from coma because like this will happen. This is reversible. So we spend basically 1/3 of our lives in this stage. And sleep is not a passive state. Sleep is a very active state. It is dynamic and highly regulated with a complicated series of brain states that repeat themselves in a characteristic pattern. So basically, in broadly, sleep is divided into two stages: non-REM and REM. So the term REM stands for rapid eye movement. So basically, sleep is defined like from a behavioral perspective from what we see, what we observe, and by electrophysiological recordings. That is by electrooculography, electroencephalography, and electromyography. So rapid eye movement is that during this stage of sleep, there are frequent bursts of eye movements that occur. So REM sleep is also known as paradoxical sleep. Paradoxical in the sense because the EEG in this sleep, it resembles to the EEG which we see in the awake pattern. But non-REM sleep is known as orthodox sleep. The EEG is similar to that, like it stands by its name. The EEG is similar to that of sleep. So there was an earlier past classification which divided sleep in non-REM into stage 1, stage 2, stage 3, and stage 4. But now stage 3 and stage 4 have been clubbed into N3. Now, according to the American Academy of Sleep Medicine, we have 3 stages: N1, N2, and N3. So how do these stages they occur? So basically, for example, first of all, when we are awake, then we go to then the non-REM stages start, the N1, then the N2, the N3, and then the REM. So like this whole cycle, this one cycle, it lasts for around 90 to 110 minutes. Now, regardless of the number of hours we sleep, the proportion of time which is spent in each stage, it remains same. But what happens is as the night progresses, the duration of REM sleep keeps on increasing, and non-REM, these deep sleep, it keeps on decreasing. So this is the pattern which is followed. Now let us see the brain wave frequencies which are associated with sleep. So first of all, when we are we talk about wakefulness. So when we are awake, these frequencies, they are seen in EEG. So in awake state, we have beta waves. They have the frequency of 12 to 30 hertz, And as we can see here, these are very high frequency waves with a very less amplitude and less voltage. So this is when we are awake with our eyes open. Now, when we are a bit calm, relaxed, and with our eyes closed, we have the alpha wave. So this is the alpha wave, which stands at 8 to 12 hertz. Then, as we go into deep relaxation and meditation, lighter sleep, we have theta waves. Theta waves are 4 to 7 hertz. Then finally, the delta wave, which is the slow wave sleep. This is the deep sleep. So this is the delta wave. It has very less frequency, 1 to 4 hertz, and high amplitude, as we can all see. So now this is the stages of sleep. So as I mentioned that we define sleep from a behavioral observation and from the electrophysiological criteria. So we have the EEG, the EOG, and the EMG. So in wakefulness, stage W. So as I mentioned that we have the beta wave when we are awake and alert. Then as we close our eyes, we have the alpha wave. So we have beta and alpha waves which are seen here. In electrooculogram, eye movements they occur, and in EMG electromyogram, we see high tonic activity and voluntary movements. Then as we progress to sleep, we have the NREM sleep, stage 1, stage 2, and stage 3. In stage 1, we have the theta waves, like we have progressed towards the lighter sleep, which stands at 4 to 7 hertz. In EOG, we have slow eye movements, and EMG tonic activity slightly decreased from wakefulness. Then in stage 2, we see sleep spindles and K complexes. We'll see it further in the next slide. Then in stage 3, we have the slow wave sleep, that is the delta sleep. Then in REM sleep. Now in REM sleep, there are rapid eye movements, bursts of eye movements. But in electromyography, there is atonia. So basically in REM sleep, there is total atonia of skeletal muscles except for extraocular muscles and diaphragm. So REM sleep is characterized by atonia of other muscles and rapid eye movements. So REM also has basically two components, the phasic REM and the tonic REM. So the tonic REM is the persistent sleep. This is generalized decrease in tone of skeletal muscle, except extraocular muscles and diaphragm. And then the phasic or the episodic sleep, which is sympathetically driven state characterized by irregular bursts of rapid eye movement. So as I mentioned, REM sleep is the paradoxical sleep, and the EEG is similar to that of like when we are awake. And sawtooth wave we also see here. So now let us see this one. In this picture, we can see with our eyes open, we have the beta waves. So beta waves are high frequency waves with less amplitude and less voltage. Then with our eyes closed, we have the alpha waves. So as we are going down, so the frequency of the waves are decreasing, the amplitude of the wave is increasing. Then in stage 1, we have the theta waves, the lighter sleep. Or sometimes we also see sharp waves, which are known as vortex waves. Then in stage 2, we can see we have a sleep spindle here. That is, these are bursts of frequency. Like these are like around 12 to 14 hertz. And then we have K complexes. K complexes is a sharp negative wave followed by a slow positive wave. Now these sleep spindles and K complexes on the EEG, they basically they refer to the memory consolidation. Then we have the slow wave sleep, which is seen in stage 3 and 4, the older classification. And we have the delta waves here. So these are very slow waves. Then in the REM sleep, sawtooth waves. So these are the various stages of sleep. Then effects of age on sleep. So the development of EEG pattern, they start at around 24 weeks of gestational age. Then the differentiation into active. In children, we call REM sleep as active sleep and non-REM as quiet sleep. So the differentiation into active and quiet sleep occurs in the last trimester. Now, infants, they do not show strong evidence of diurnal sleep patterns for the first several months of life. And they exhibit short sleep-wake cycles of around 3 to 4 hours, as well as the reduced length of active quiet sleep cycles, about 15 minutes. Then at birth, active sleep, which is the REM sleep, occupies half of their sleep time. And like infants, they enter to, like we as adults, we enter the sleep first through non-REM, then REM, but it is reversed in infants. Infants, they enter the sleep through REM, and most of their sleep is occupied by this REM sleep. Now, at 3 to 4 months of age, they shift to the adult-like pattern of sleep. Now, young children, they show the highest proportion of slow wave sleep, and hence, like most of the bedwetting and various parasomnias which are associated with deep sleep, they are seen, like sleepwalking, somnambulism, and night terrors, they are seen in young children because they have highest proportion of slow wave sleep, and these disorders, parasomnias, are usually seen in slow wave sleep. Now, slow wave sleep, it declines across adolescent, and it disappears entirely by around age 60. Now, as the age progresses, sleep becomes more fragmented. Like there's a prolonged latency to sleep onset, like the duration between lying down on the bed and sleeping actually, that is also increased. Increased number of arousals, more time spent awake during sleep, and increased daytime napping. Now, according to the CDC, this table it shows the recommended hours of sleep per day. So, as we can see in newborn from 0 to 3 months, like the recommended hours, they are 14 to 17. Then, as the age progresses, we can see in teen we have 8 to 10 hours. Then in adults, 7 or more hours. Now, let us come to physiology of sleep. Now, we'll be seeing various systems of the body, which how they are changed, how they're affected during sleep. Now, autonomic nervous system. So, in non-REM sleep, and in this, as I said, that in REM sleep there are two. It is like it is divided into two parts: the tonic and the phasic. So, the tonic REM and the non-REM, they have increased in parasympathetic activity, and the autonomic nervous system, it reaches its most stable state during slow wave sleep in comparison to wakefulness. During phasic REM sleep, there are brief surges of sympathetic activity. In cardiovascular system, like as I mentioned, parasympathetic system is activated during non-REM sleep, and so blood pressure, heart rate, and cardiac output, they decrease during the non-REM sleep, reaching their lowest average values and least variability in slow wave sleep. Arrhythmias, it is said that they are more common in REM sleep. So the cardiovascular mortality is more common in early morning. So this is also associated with basically patients of depression. They have more of REM sleep, and hence more cardiovascular mortalities are like seen there. In sexual function, in REM sleep, basically there is occurrence of penile erections, and in women there is increased vaginal blood flow and clitoral erection. These changes are not necessarily linked to the sexual content in associated dreams. Neuroendocrine changes. So, like growth hormone and prolactin, they are released after the onset of sleep. Growth hormone, in turn, it stimulates slow wave sleep, and prolactin, it stimulates REM sleep. Thyroid stimulating hormone, we know it reaches its peak level in the evening just prior to sleep onset, and its secretion, the TSH secretion, it is inhibited by sleep and stimulated by sleep deprivation. The HPA axis, the hypothalamus pituitary adrenal axis, is also inactive during nocturnal sleep onset. The cortisol levels, we know that they rise during the early morning hours, and at night they're less. Melatonin secretion, it occurs in response to the light dark cycle. Thermoregulation. So brain and body temperature, they are down regulated during non-REM sleep by the hypothalamus, particularly slow wave sleep, as a result of both decreased hypothalamic temperature set point as well as active heat loss. In the respiratory system, during the non-REM sleep, the minute ventilation falls with the onset of sleep. Like the respiratory pattern is more regular than the wakeful breathing in the non-REM sleep. And the lowest point of minute ventilation in non-REM sleep occurs during the stage 3, that is the slow wave sleep. In REM sleep, the respiratory patterns in control vary, reduced regularity. Tidal volume is reduced further in comparison to that of non-REM sleep. Now let us come to neurobiology of sleep. So basically, this is a very important part, the neurobiology. So as we can see in this picture, so this picture basically it shows the arousal spectrum. So here we are in the like middle, we are alert, awake, creative, problem solving. So now if like the arousal is increased, there is excessive arousal. So there is hypervigilance in the morning and there is insomnia in the night. So that is why we give hypnotic drugs. So as to decrease the arousal and come back to this. Then if there is like arousal is decreased. So if like the arousal is decreased, this leads to narcolepsy and more daytime sleepiness. So basically we have to maintain this, the middle part, and this is basically regulated by variety of factors, which we'll be studying ahead in the further slides. So in the neurobiology of sleep, we'll be covering what are the wake promoting systems, what are the sleep promoting systems, the arousal systems, this circadian wake drive and the homeostatic sleep drive, melatonin and suprachiasmatic nucleus, then REM off and REM off, on and off. So first of all, let us look at this picture. So in this picture, as we can all see, so this picture, basically, first of all, we'll be reading a bit about what hypothalamus and thalamus, so as to build a concept. So so this is here, we have the hypothalamus here. And like a cut section of this. So hypothalamus, it basically lies just below the thalamus and above the pituitary gland. So we know hypothalamus is basically, it connects the nervous system to the endocrine system. We all know that hypothalamus releases various release hormones like the gonadotropin release hormone, the growth hormone release hormone, corticotropin, and the thyrotropin release hormone. Also, hypothalamus is basically, it acts like a set point. So it controls all the basic functions. It controls the temperature of the body. It controls the appetite. It controls the hunger, thirst, blood pressure, sleep, sexual drive. Like all the basic functions of the body are controlled by hypothalamus. Now we will be studying how hypothalamus, it controls the sleep. So there is a nucleus in the hypothalamus which is known as the VLPO, the ventrolateral preoptic nucleus. Now this VLPO nucleus in the hypothalamus, it releases GABA, which is an inhibitory neurotransmitter, GABA and galanin, which is a neuropeptide. So now this GABA and galanin, when they are released, they promote sleep. So the VLPO in the hypothalamus, it is promoting sleep. Also, the VLPO is activated by adenosine, which we'll be studying further how. So VLPO will secrete GABA and galanin, and they promote sleep. Now let us come to thalamus. Now why thalamus is important? Now, first of all, what is thalamus? Thalamus, as we saw in this picture, thalamus is situated like just above the hypothalamus, as the name suggests. Now thalamus is a paired structure of gray matter, which is located in the forebrain. Now thalamus, it acts as a relay station. So whatever information is coming, whether sensory or motor, anything, so thalamus will act as a relay station, and from thalamus there are various cortical projections to the whole brain, and thalamus will supply signals. It will send signals to the cortex from the whole body. Now thalamus also has roles in consciousness, sleep, and alertness. It is said that thalamus plays a very vital role in regulating arousal, the level of awareness and activity, and damage to the thalamus can lead to permanent coma. Now thalamus, it has various nucleus, I mean. So as we can see here, there are multiple nucleuses which are involved in the thalamus. Now these nuclei of the thalamus, they are stimulating nuclei. That means we have the thalamocortical projections from these nucleuses, and these are all stimulating. That is, they activate the cortex. So these nucleus from the thalamus, they will activate the cortex, and hence they promote wakefulness. But there is one nucleus which is important for us, which is the nucleus reticularis thalamus. Now the NRT. Now nucleus reticularis thalamus is the only nucleus in the thalamus which is inhibitory. So what this nucleus does is, see the other nucleuses, they were projecting to the cortex. All the other nucleus of thalamus, they project to the cortex, except for this nucleus. This nucleus, it projects to other nucleus and not the cortex. So what this nucleus does is, this nucleus inhibits all the other nucleus of the thalamus. So when all the other nucleus of the thalamus, they are inhibited, so their stimulation to the cortex is also inhibited, and hence it will promote sleep. So this is the NRT, nucleus reticularis thalamus. This is very important. Now we'll be studying further the reticular activating system, or the ascending reticular activating system, which will also act on the NRT. So that is why it is important. So now what is the RAS, or the reticular activating system? It is a set of interconnected nuclei which are present in the brainstem. Now RAS is also of two types. It is ascending and the descending. So the ascending pathways is to the cortex, that is the ARAS, and then we have the descending pathways to the spinal cord via the reticulospinal tracts. Now the ascending RAS, as depicted in this picture, it is a collection of various nuclei, more than 20 on each side of the upper brainstem, pons, medulla, and posterior hypothalamus. The neurotransmitters which are involved are dopamine, norepinephrine, serotonin, histamine, acetylcholine, and glutamate. So now let us understand how basically ARAS is involved in sleep. So there are two pathways of promoting sleep or wakefulness, the sleep-wake cycle. So we have the thalamic pathway and we have the extrathalamic pathway. So as I mentioned about the thalamic pathway. So as I mentioned in the previous slide about the NRT nucleus of thalamus. So the NRT nucleus of thalamus, it will inhibit all the other thalamic nuclei, and hence the stimulation to the cortex is inhibited. Now ARAS will inhibit this NRT. So when the nucleus reticularis thalamus is inhibited, its inhibitory control over the other nuclei is also inhibited, and it will promote wakefulness. So like, okay. So the extrathalamic pathway is via the forebrain and the hypothalamus. So the ascending reticular activating system, it basically activates the basal forebrain, and from the basal forebrain, in the basal forebrain, we know we have the cholinergic neurons, and hence arousal is stimulated. And then via the hypothalamus is basically the home to the tuberomammillary nucleus, which has the histaminergic neurons, and hypothalamus also releases orexin. So via this extrathalamic pathway, the ARAS, it stimulates the release of orexin. Now, orexin is the master regulator of sleep. Orexin will further stimulate all the other neurons to stimulate, like to produce other neurotransmitters which are involved in sleep. So now these are the wake, this is the wake promoting system. So these first 5, these are the monoamines which promote sleep. These include the noradrenergic neurons from the locus ceruleus, serotonergic from the dorsal raphe nucleus, dopaminergic from the ventral tegmental area, glutamate from the parabranchial nucleus, then acetylcholine from the nucleus basalis of Maynard and the basal forebrain, then orexin or hypocretin from the hypothalamus, and histamine from the TMN. So orexin has been highlighted here because orexin is the master regulator, and it further projects its neurons to all these other nucleuses, which lead to the production of these neurotransmitters, and they enhance wakefulness. So orexin is the master regulator of wakefulness. Then in sleep promoting system, as I mentioned in the first slide, we have the VLPO, which secretes GABA, and GABA promotes sleep. And then we have melatonin from the pineal gland and the REM switch will be further. Then the circadian wake drive and the homeostatic sleep drive. So the regulation of the daily cycles of sleep and wakefulness is mediated by two opposing drives: homeostatic sleep drive S and the circadian sleep wake drive C. So the longer we are awake, we are awake during the whole day, so fatigue sets in, and there is also accumulation of adenosine. So during the end of the day, when the adenosine levels are very high, the adenosine, it leads to disinhibition of VLPO and release of GABA, which promotes sleep. So also when as the day passes by, the light fades. So during the whole day, the orexin, which was the master regulator, it was responsible for activation of wakefulness and release of all the other neurotransmitters. So there is accumulation of all these neurotransmitters, norepinephrine, serotonin, histamine, throughout the day in response to orexin. So they are all accumulated. So when these are present in high amount, there is a negative feedback mechanism to orexin. So orexin is now reduced and wakefulness cannot be stabilized. Also at the same time, because adenosine was very high and adenosine led to a discharge of GABA from VLPO, sleep is facilitated. Then we all know about the melatonin. Like melatonin is secreted from the pineal gland. So we have the when there is light outside, so the retina, hypothalamic fibers, they synapse in the suprachiasmatic nucleus, and then via chain of reactions, there is release of melatonin from the pineal gland. Now, the REM on and REM off, these are basically, this is the REM on and REM off switch. So normally, if you look at this part, So normally REM off, it inhibits REM on. So REM on is inhibited. So like wakefulness, if we look at just this part, so wakefulness is stabilized. We are awake. So now ARAS, the ascending reticular activating system, and orexin, which are wake promoting, they activate, they further stimulate the REM off. So REM is off. REM is not like when REM is off, it will inhibit REM on. So wakefulness will be there. No REM sleep. Now the VLPO, now during the end of the day, the VLPO, it basically it inhibits these ARAS and orexins, which are wake promoting, and it stimulates REM on. So so sleep is promoted, and here wakefulness is promoted. Also, what happens is that REM on, like during sleep, it also stimulates the basal forebrain, just the cholinergic neurons, and this leads to the stimulation of cortex, and there is dreaming and hallucinations during sleep. Also, the spinal cord motor neurons, they are inhibited, and this leads to atonia, which is which is seen in REM sleep. Now, what is sleep hygiene? So, sleep hygiene basically it involves multiple things for multiple things. For example, to have a good sleep hygiene schedule, it involves a good consistent sleep schedule. Get up at the same time every day, even on weekends or during vacations. Set a bedtime that is early enough for you to get 7 to 8 hours of sleep. Establish a relaxing bedtime routine. Make your bedroom quiet and relaxing. Like it should be dark. The exposure to bright light should be limited. All the electronic devices like which give blue light also, they should not be used at least 30 minutes before bedtime. A large meal should be avoided before bedtime. Exercise should be done daily. A healthy diet should be maintained. Tea, coffee, or alcohol, all the other stimulants, they should be avoided in the late evening. And fluid intake should also be restricted before bedtime. That picture I have not inserted here. So basically, when light strikes the retina, so from the retina, there are retinohypothalamic fibers. Okay, they go and they synapse in the suprachiasmatic nucleus, which is connected to the sympathetic preganglionic neurons in the spinal cord, and they project further to the superior cervical ganglion. Then postganglionic fibers from the superior cervical ganglion, they relay in the pineal gland, and the pineal gland secretes melatonin.
Can you go back to EEG? In which phase the person is asleep? Like you can say that he was
N3, sir. Yes.
if he was observing, then you can say that
Yes, sir.
stage 2 में K complex और
The K complexes and sleep schedule.
sleep startles क्या होते हैं? किस phase में होते हैं?
Yes, sir. Sir, sleep starters, they occur in stage 1, N1 sleep.
क्या होता है?
Sir, sir, it is like during the N1 sleep, there are some jerks. They're like hypnic jerks. So basically, in N1 sleep, there are certain.
ऐसे
Yes.
बैठे
हाँ जी, sir. These are hypnic jerks. Yeah, correct.
जैसे से होता है sleep startles, even babies they have a lot of
They occur for like 5 to 10 seconds. These are attacks of micro sleep. They occur for 5 to 10 seconds. These are N1 sleep. And these are also very like harmful for people who are driving or who are sleep deprived.
then you tend to go into NREM and then REM. Children can directly go into REM. Okay. Also, if you're sleep deprived, then you can directly go into REM. What about benzodiazepines? What do they do? Sleep architecture.
Basically, benzodiazepines inhibit the REM sleep. So, like whenever when there is benzodiazepine dependence and then they're withdrawn. So this leads to REM sleep. REM withdrawal.
So if somebody is taking alcohol, for example, okay, this is a REM sleep with alcohol. So what is the problem? If taking benzodiazepine and alcohol for sleep, what's the problem?
So they alcohol and benzodiazepines still inhibit the REM part of the sleep. But when the patient will stop taking alcohol or benzodiazepine, they will.
But if they are taking dependence for sleep, they're taking okay. The respiratory part in NREM, that is not. What about antidepressants?
The same.
Do they do? How? Depression with the REM sleep tends to occur more and the antidepressant actually increase the NREM. They bring back the physiological part. Okay. When is a person more likely to wake up during the night, during the sleep? रात में अगर नींद किसी को तब REM में कभी REM बढ़ता रहता है जैसे in the later part your REM part is more increased. During the entry speed the person wakes up is उसकी confused. तो एक तो होता है कि आप धीरे धीरे उठता है REM में इस entry में तो नैप का टाइमिंग कितना होना चाहिए डे टाइम नैप हो तो कितनी होगी इसी से आएगा again if you go into N2 N3 the person will wake up confused. Okay, so for to like naps are suggested you lie down for some so not more than 30 to 40. So then you will go into N3 N4 deep sleep and if you wake up from them that then the person will not be refreshed. It is like you want to just charge your batteries. So just for 30 to 40 minutes you lie down. So don't go into deep sleep. It's good. To be we dream. We dream in both entry also REM also. But the dreams of REM we are able to remember and entry we are not able to. And the REM part dreams are more, you can say, they are systematized. Okay, and these are very psychotic-like state. With logic in involved. That is why sometimes I am having bad dreams. It is because they are consistently waking up in during that phase, all the like the very disturbing, non-logic, so happens in depression that gets in the time. Like nowadays, I'm very frequently bad things. It is because they are not picking up in the REM phase. Okay. When does night terror happen? Night terrors are they happen. What about REM? REM, instead REM, we have behavioral disorders. Okay. So, for example, there is atonia is not there of sleep, so the patient with NAC. Somnambulism. So, it happens. Sleep happens in sleep. Depending upon what disorder you see, you can choose a medication similar. Okay. Antidepressant long again. depending upon when the your event is occurring, then also you can see night terrors they occur. वो साफ से आगे बढ़ता जाएगा तो so if you want to take history for sleep, what are the issues? Yes, it is. So going to bed, okay, giving the bed and time taking to sleep, time how much you wake up, okay, any time that you how many times you get out of bed, simpler refreshing, non refreshing, daytime sleep. When you're doing polysomnography or watching the, no, it's a very agonizing progress. Like if you're titrating or if you're waiting for a person to go to sleep, you are sitting in front of a monitor and then these waves keep on coming and then sleep spindles, K waves will start coming and you say, okay, that person is now about to go to sleep. And then suddenly he'll revert back to the wave, the wave because uh, polysomnography, polysomnography करते हैं manually, करते हैं, sleep cycle करते हैं, कैसे होती है. I'm done a bit. Ravi is very sleep specialist, so just you keep on waking yourself up is very sleepy and the waves are coming in and then the, the patient has gone to sleep. Okay. And then you throughout the night you score the sleep, how much amount of time is spent in what EV monitoring करते हैं, EEG करते हैं, oxygen saturation measure करते हैं. Very, very useful. You can